you, Lynn. And thanks to everyone for being here. I see plenty of familiar faces, some who I haven't seen in a while. Hello. And I heard, is it Elisa? Is that how you say your name? 22 years. And today I'm going to talk about progression and next line therapies. And in your 22 years, 22 years ago, there really weren't a lot of second line options. It was really a tough time in the management of lung cancer, and certainly an explosion since then. So I'm going to chat, and for people that know me, I am super passionate about what I do and ensuring that we always have an honest conversation, but also one that is full of hope and real understanding of where things are going. And so with that, I'm going to talk, and I may not answer your questions. So if you have one, write it down in the chat or do something. And so we'll make sure that we address it afterwards. But my focus for today is really about, progression and what to do. I mean, I think it's really, it's terrifying to have the initial diagnosis. There's a certain sense of relief when you start. Bye, Janet. There will be a certain sense of relief when you initiate your first treatment, because you feel like you have an action plan and that you're doing something productive. Yet there remains this fear and angst of what happens next, and what is that going to look like, and what is life going to be like, for that word, progression. And I think that when and I'm going to give you my perspective as a medical oncologist and thoracic medical oncologist, is really we start thinking about progression at the time of diagnosis, or I do. When I say we, I mean I. I really start creating a short-term and a long-term strategy for a treatment course, and really want to think about duration, durability. What does this look like? Not today, but whether that's months or years from now, when we need to readdress another treatment. And, a lot of people who talk with me know I use a lot of analogies, but I do think it's important to really start thinking about lung cancer as a chronic illness, and how do we create that chronic illness? Much like when we first encountered the HIV virus and AIDS, and the fear and the unknown, and then really recognizing that we can make that a long-term process. Or even diabetes, which is another long-term illness that can have devastating consequences. But there are times when you may have to escalate therapy, add new therapies. For example, if you're on metformin and you need to add insulin, the way that I think about cancer progression is that we're going to need to adjust. This is an expectation. And so to go into a cancer diagnosis and understand that at some point, the first therapy may not be achieving our goals. And I don't look at it as defeat. I look at it as a reassessment and a dynamic in which, what can we do to be better than where we are today? And so I think you have to go into it recognizing that at some point that will happen, and then how do we approach that next step? So we set goals when we start a treatment. We say, and for me, and I think that this is a lot of a misperception about what are the expectations that I achieve out of my first line treatment, right? Cancer, is oftentimes not just going to disappear and stay away for forever. And so I think that a lot of times we set ourselves and our emotions up inappropriately for that first scan. And you'll see one of us celebrate a report when really nothing's changed. But it's important to think about those goals. Really, for a treatment to be effective, we want nothing new. We don't want to see new disease being identified. We also don't want the disease that we know about to grow, right? So that demonstrates that there's a lack of control with the current treatment. And then I look at it as an added plus when we get shrinkage. And there are a lot of situations in which that's very important. If there's compression or if it's causing symptoms, we want to actually demonstrate that response. But as I talk about in clinic, it's much like a car, and my husband drives manual transmission vehicles. And so, it's very important to get into neutral to shift your gear, right? And so you have to create neutral position before you can throw it into reverse. And part of that is, using both of those gear shifts and putting on the brakes, and that has to happen in the cancer response. And so, and another thing that I look at, in trying to figure out, is our treatment working, is, and I'll use this analogy as well, as to establish a perimeter. A lot of times in systemic treatment, what I mean by that, as many of you know, is like an IV, an oral, something that's going to touch the whole body, not a localized therapy that is a radiation or surgery, but something that's really capturing the whole body. And we use that to establish a perimeter. We really need to get a hold of everything. And once we've captured that, then we can start tweaking, and then we can start really looking at how do we get a little creative. What are some areas in which we can use our other local techniques to maximize our benefit? When we start with a first line treatment, we're already thinking about second, third, fourth, etc. And these days in lung cancer, that really is a possibility with all of the advancements that we've made, that we have multiple options. And the question is the sequence, right? What is the order of operations? And that is very dependent on the tumor itself. And so although there are many first line options now available, there are variations in all of those. Some of them may include targeted therapy for mutations within the tumor. Some of those may include still standard chemotherapy. However, that chemotherapy may be tiered for the histology of the cancer, like a non-squamous non-small cell lung cancer. There may be also immunotherapy, and we know that there are various types of immune-based therapies that target different parts of the immune system, and some are single and some are in combination. And then there's the anti-blood vessel kind of treatment, antibodies, bevacizumab, ramucirumab, to name two of them. And so all of those have FDA approvals because they've demonstrated efficacy and safety. But we need to ensure that we choose that right first line treatment that best fits the tumor and the person. And so as we're thinking about that first line treatment, we are also thinking about what would we do next, okay? And so that is really important to consider. For example, we know that if a tumor has a driver mutation in it, and whether that's EGFR, ALK, ROS1, BRAF, TRAC, RET, MET, the KRAS inhibitors are not yet approved in the first line setting. The EGFR, the HER2 agents have yet to be FDA approved in any line. And then we've got our exon 20 insertion agents that are not approved in the first line setting. But if we find one of those driver mutations, we know that doing targeted therapy up front is the most beneficial. And so that would be our goal, to make sure that we're looking for those mutations and that we're starting that first. If we've got if we identify one of those, we certainly do not want to use immunotherapy in that first line setting. And there are a lot of caveats to that, but the sequence is very important in that first line setting and helps set the stage for the next line setting. And I think that when we are getting scans, as we kind of think about, so what do we do once we're on our first line therapy and we're getting our scans, and we're starting to get into that discussion about whether or not there's stable disease or progression or, a complete response or whatever criteria we may use. you know, we really want to be thinking about a couple of things. And so what does that look like? You know, and when do we implement a next treatment, and how do we really define progression? So what is progression, right? I mean, what does that really mean? I mean, there are in fact objective criteria that we use that define progression, and that's based on RECIST criteria. And it's important for everyone to know that there is an objective measurement that goes along with that. And that's because we have clinical trials that are assessing the benefit of a lot of agents, and that's done at many different centers. Sometimes it's being evaluated by the medical oncologist or the radiologist, and some, you know, people have different platforms for their radiology, and sometimes it's done internationally. So it's very important that we're all evaluating this on the same scale. So there is in fact an international criteria that helps us define what progression is. And really we have what, you know, for anybody who's enrolled or engaged in a clinical trial, we define what we call target lesions and non-target lesions. We measure those, and lymph nodes are measured differently than a soft tissue tumor, and bones are looked at very differently. And then when we do our set of scans, we determine how those measurements have evolved. Are there anything that's new? Has anything disappeared? And based on RECIST, in order to have a response, it needs to be like a partial response. A partial response is considered 30% regression. And so you can imagine when your medical oncologist says these are actually stable, but you're looking at the scan report and you see millimeters of difference, in your mind, you know, there may be some disappointment, or you think that we're absolutely bonkers that we aren't reading these numbers, when in fact we recognize that minimal changes are in fact within a certain range of acceptable findings. And that's because we expect some things to be, you know, adjust over time. You know, people aren't always like in the scan perfectly straight every time, and there may be a little bit of a shift that measures differently. The other thing I always talk about is that depending on the type of CT scan that you have, those pictures are taken every 2.5 millimeters, which is super tiny. But if you see a 2 millimeter change, that's out of the window of those measurements. And so it's really important to understand, you know, when we feel like that things are stable, that there may be some objective component to that definition that we've applied. For progression, it's a little bit differently. We're not going to allow things to get up to 30% before we identify that progression. It's actually a cutoff of 20%. So if we see growth in those target lesions or something new evolve, then that's actually progression. And so Terry's asked, you know, what do you see different in a CT scan versus a PET scan? And I'll just talk about that right now. It's really that, you know, I actually, for measurements, prefer CT scans, and most clinical trials are going to have that as an expectation. And the reason for that is that the quality of the image is superior on a CT scan. It's right now the CT scans, you know, are designed for these. I mean, you can get pictures every 1 millimeter on a CT scan, and it's you don't have to have contrast to get a good picture of the lungs. The contrast helps you differentiate lymph nodes from blood vessels, especially in the middle part of the chest, what we call the mediastinum. But we can get a really good picture and still get that same quality even without the contrast. A PET scan, the pictures are most often taken about every 4 millimeters. And if you look at one of your PET scans compared to one of your CT scans, you'll really start to notice that the quality is very different. And the goal of the PET scan is not for serial tumor measurements. It's really to determine if something's hypermetabolic or lights up bright, which, quite honestly could still be infection, inflammation. It doesn't have to be tumor, because we recognize that although lung cancer lights up bright on the PET scan, there are limitations to the PET. It's not a cancer scan. It shows us activity, and some tumors have low activity. Some tumors that have been radiated may have no activity, and some tumors that have been radiated may light up really bright because they're on fire and they're hot. So it can be very misleading and poorly interpreted. The question was about an adenocarcinoma in situ and whether that lights up. It's a great question. So the WHO, World Health Organization, and pathology definitions have evolved for like an adeno in situ. And really these very slow growing small nodules is essentially what we're talking about, that really have cancer potential, but they're very, very slow, and they may not ever become anything. They tend not to, right? So they don't have a lot of metabolic activity. They're not turning over, so they may not light up. And they may also, because they're most often small, be limited in the ability to uptake that FDG dye that we give when we get a PET scan. And so, the limitation of PET is also not only the metabolic activity, but the size of the lesion and the ability to uptake that dye. And that may even be limited up to 1 centimeter. And so Dusty has a great question with a slow growing tumor, but still very large. Is that considered in situ? Nothing is considered anything unless it's pathologically confirmed. And so one of the things that's really important is we don't label anything, or I don't label anything unless I have it under the microscope. And for people that may not have a lung adenocarcinoma or a non-small cell lung cancer, they may have a carcinoid or a pulmonary carcinoid. That's a neuroendocrine tumor that may have a low grade uptake or may not be taken up on a scan. So, and thinking about how we use these scans back for progression and talking about, what does that look like if we, talk about subjective, right? I mentioned like how we look at this objectively on a numerical basis, but really then what does that mean? And how do we, when your oncologist says, well, it's a little borderline, or we've got a little growth here, or there's one thing that's just misbehaving. There are other definitions that we throw out. One is called oligo progression. And that's a big word just to say there might be just something going rogue in one nodular tumor. Oligo means one, or, kind of singular. And so you could be receiving a treatment that's providing great control everywhere, but there's like, and I liken this to like the classroom, right? There's always one person that just can't sit still. And so there may be one tumor that's just kind of going rogue, but you still have great control with everything else. And so what we've learned with lung cancer is maybe we can kind of give that one some detention without putting the whole class to miss recess. And so you may be able to continue on your systemic treatment that's controlling everything else and do something novel, such as some radiation to a single site of progression. The definition of oligo progression is one in question. You may hear some people refer to it as singular. In some clinical trials and with some oncologists and radiation oncologists, that may vary up to 4 to 6 lesions. And there are some clinical trials that are looking at management, local management of oligo progression up to 4 to 6 lesions in lung cancer. So that definition is variable, but we do feel like, there may be something unique that's going on with that single lesion, but not have to change the whole course of therapy. And so I think that's really something that's important to consider, that all progression is not the same, and that there are many opportunities. And so, we talk about these like little leaky tumors. What do we do about that? And how do we optimize that next line treatment? Because I already told you, that you have options. And so if we are looking at something that's gone rogue, or if we look at something that just doesn't seem to demonstrate that ongoing benefit that we were trying to achieve, what can we do when we think about that, our next options? Well, first and foremost, I'm a huge advocate of information. Okay, we make smarter decisions when we are educated. I am not somebody to ever jump off a cliff. I'm going to find the path. I'm going to walk down it. And so what that's going to involve for me is additional analysis. A lot of that has to do with comprehensive imaging. So if we identify something on a single scan that may show a change, or let's just call it progression, I will go ahead and do, kind of the head to toe thing. I want to reassess the brain. I want to know how the rest of the body is doing. And that also provides us a new baseline so that we really, we know at starting point 0 that everything on this date is where it was. And so there's no time bias or question as to whether something was changing or not at that interval. So re-imaging. The next is the molecular analysis, right? So this is what is really changing, and that's not just from a tumor mutational perspective, but maybe even in other markers. Today, I received an email about a potential clinical trial looking at anti-folate markers. And just to give an example of that, pemetrexed or Alimta is an anti-folate agent. And so there's a drug that's in development that has an anti-folate ADC, and this is a lot of mumbo jumbo language, but they're trying to optimize other chemotherapeutics, not just targeted therapies, not just immunotherapies, but a lot of this is based on tumor. So fresh tissue biopsies, getting another sample so you can determine how a tumor has changed. This is imperative if a tumor has a mutation in it. If there's a known tumor already, that tumor changes to circumvent the current therapy. And the way that progression happens is often like a waterfall, in the sense that you've got a waterfall and we put the boulder down, with the targeted therapy, but eventually you get that drippage of, some water through gravity that kind of lets it seep out, and you've got to know what that path was. So, if there's fresh tissue available, then we are going to biopsy that. I always parallel that with blood. So I'm going to do both, and if the tissue's available, then yes. And so we do that through a needle biopsy, and that may not be actually tissue. It could be an effusion. Sometimes a pleural effusion has enough cells that we can make a cell block. Pericardial effusion, which is around the lining of the heart, may have enough cells to make a cell block. But I always, I just tend to be, I don't know, comprehensive, I guess is a good word, but I do blood and tissue at the same time. That's really important because, blood has limitations. You can get false negatives if there aren't as many tumor cells in circulation. Tissue may be limited just based on the dartboard that you're going up against. And so it's really nice for me to have both of them. And I think it's important to recognize for y'all that, as the world has shifted to next generation sequencing, we can get these 600 gene panels, and so we're looking at tons and tons of markers. And so what does that give us, right? So after we've done all this, we've said, okay, we've got progression. We've decided whether or not we can just do some quick radiation to this, or whether we really need to make a shift. We've re-imaged. We've said, let's get some more information through blood and tissue. And then how do we utilize that? Sometimes we will use a bridge therapy, and we all know that we have, and me included, have a tremendous amount of impatience with getting results from our next generation sequencing. That can take a couple of weeks. And if somebody's having any kind of issues, there are bridge options, right? Can we bridge with some chemotherapy? Is there something else that we should do if we're in an emergency? Most of the time you will find that we prefer to wait and get all of our information and maybe use that time for recovery of blood counts and maybe even a vacation or something like that while we gather that information and make some smart decisions. So our next line options, they are abundant. You may not feel that way, but there are options. And that is standard of care. So standard of care may include a chemotherapy option. Most of our next line options right now are chemotherapy based, but I think it's really important to recognize that chemotherapy is not the enemy. Chemotherapy has been around for a long time, and what may not have worked the first time, the next group may. And some of these next line chemotherapies have been the backbone of lung cancer treatment for quite some time and have demonstrated efficacy. So, and I've had plenty of people that have had very long-term responses to next line chemotherapy. So I don't find it discouraging. I just look at it as another opportunity to try something different and really, go at it, through different mechanisms and use a totally different mechanism of action. Clinical trials are tremendous these days, and they are really providing opportunities both from an immunotherapy perspective and from a targeted therapy perspective. I'll start with immunotherapy. So right now, we are using PD-1, PD-L1 inhibitors. We know that the immune system is super complex and has multi-different facets to it, whether it's TIGIT, CD28, there's so many different components to our immune system, CTLA4, which is more along the lines of ipilimumab, that we can tap into. And there are many studies that are looking at other ways to target and enhance the immune system beyond our PD-1 and PD-L1 inhibitors. And so those are mostly clinical trial based, and some of them are by themselves and some of them are in combination with chemotherapy, but those are actually quite abundant. From a targeted therapies perspective, again, it's very important to know your molecular profile. And in that 12-page document that you get that's super confusing and overwhelming, put a lot of information in that. It's not just about some of the significant findings. What I'm actually also looking at is the variance of unknown significance. All that means is that we haven't figured it out yet, but it doesn't mean that we aren't working towards that. So a variant of unknown significance may actually be something that we're researching. There may be a clinical trial that's looking at some of those variants. And so it's important to me to look at the entire profile that's being identified. For example, there's a clinical trial called a TAPER study, and that's through ASCO, American Society of Clinical Oncology. That is actually using FDA-approved agents. For example, let's say that there's an FDA-approved agent in kidney cancer for a certain target, And then, but it's not been FDA approved in lung cancer, but you have a lung cancer and the tumor has that mutation in it. The TAPER study may have that available to you. And so it's a targeted, you've heard of lung map and things like that. It's basically a targeted driven study that allows you to get off-label use on study of an FDA approved agent. The benefit there is we already know the side effect profile, we know how it's working, we're just using it in a different capacity. And so it's a phenomenal opportunity, and they're continuing to expand and open different options there. The other thing that that I would say, and there was a question too about like wild type or hold on, let me pull that up. What is the difference between wild type and negative on a report? Not much. So really, it depends on. So if something's going to say EGFR wild type, there's not an EGFR mutation identified in there, and so it's the reports are very terrible, and there's a lot of effort right now to try and homogenize them and prioritize and have some sort of universal kind of language. You know, one of the things that we've struggled with is they may list a therapy that makes zero sense, and that can be very confusing because it may not be an appropriate therapy, and or you know, or maybe it's in trial, or maybe it's being considered, or it may list another thing that's always been concerning to me is when drugs are listed out of alphabetical order or in alphabetical order, but they need to designate that, right? I mean, they may not be listed in order of efficacy, and so there may be some confusion, like should I get this one or should I get that one? For example, in the ALK rearrangement space, we've seen some reports that I think have been misleading over the years. And I also think that it's challenging when you get a report that may say, you know, no mutations. And so is that really that you didn't have sufficient tissue, or were there truly no mutations identified? And so I think there's an effort to really try, and that's at a high level, to try and improve upon that, as well as improve the turnaround time on those reports. You know, I think that one of the things that's you know, an option too with these, a lot of these clinical trials and therapies is really that you know, just thinking outside the box, and again trying to integrate some local therapies or other, you know, options. There are you know, beyond the clinical trials, they're even phase 1, and that means that they're, you know, they're early on in development, but there's, you know, data to support it, and so those may be very early trials. And I would say that, you know, speaking with your medical oncologist and understanding what trials may be available, whether that's locally, regionally, or even nationally, you know, can be helpful. And in the era of COVID, there have been a lot of changes to the conduction of clinical trial that's been to our advantage, and a little bit more leeway in travel, a little bit more leeway in getting local labs, a little bit more leeway in scan options. And we do think, and we're pushing on a national level for that to be something that stays, that those adjustments that have had to be made through COVID and still being able to conduct clinical trials, the virtual platform should be continued for everyone's benefit and advantage. So we'll see how that goes. I'll mention the unpopular option is hospice. And I say that because I think it's fair to say it out loud. And I've had people in my clinic who have felt beat up by chemotherapy and have opted to take a break and still want to get supported and get care, and they choose to get treatment in a different capacity, and that is through hospice, which provides best supportive care. And I think it's important to talk about that always as an option, especially if it's something that you feel is right for your body and right for your time, and to understand that that shouldn't be defeat, and that shouldn't be a bad word, and it's okay to talk about it because it's an incredible opportunity. And for people that I've had that have made that decision, and I've followed up with them a lot of times, like, I feel so much better than I did. And and even if they're doing if they're doing well, and I say, all right, well, are you well enough that you want to come back and get chemo? They're like, are you kidding me? No way. Like, this is what I've been waiting for. I've been waiting to feel better. And so I think that it's really important to not feel defeated, to not feel guilty or embarrassed to even ask what your options are beyond an intervention. And sometimes those interventions may not be hospice, but is there some home health, or is there some physical therapy, or is there something else that I can do during a break time? And when is that break time opportune for me to really embrace healing and embrace life and living, which is very important. People ask me, what do I need to do, right? I mean, what can I do when they have progression or they're diagnosed? And one of the things that I think is really, that I always emphasize is move and eat. The longer that we can stay healthy and support our bodies, the longer our bodies can support us through treatment. And cancer was not invited to the body, and but we can, as long as we're supporting the body and ourselves, our mental health, our emotional health, and our physical health, then there will be further opportunities. Things are changing, more treatments, more options, and the longer that you can be moving and eating and supporting your body, the more opportunity will come. So it's that we talk about 2 steps forward, 1 step back. I mean, that's still forward progression. And a forward movement and a walk to advancement. So I think that really what I want to impart on y'all today is that although progression is a change and it does require conversation, there's a lot of dynamic and planning that goes into what happens at that time. And so I just invite y'all to be, open that conversation with your provider.